Most patients get their psychiatric care in a primary care setting for a couple of reasons. Some folks don't want to come see a psychiatrist, and for a lot of patients, they don't have access to a psychiatrist, and they have great relationships with their primary care docs, so their primary care docs are in a perfect position to be able to identify and treat these disorders. It also ends up being managed in primary care because lots of these patients actually don't realize they have an anxiety disorder or depressive disorder. The most common way these disorders present is patients coming in with medically unexplained symptoms, which is what 25 to 50% of doctor visits are about. So these patients come in distressed, present to their primary doc complaining, I'm not sleeping well, I hurt, I'm having significant issues with diarrhea. Oftentimes these patients actually have depression or anxiety, but they don't realize that what they're experiencing is depression or anxiety. What they experience are these somatic manifestations of their psychic distress. So primary care docs are then left with these patients with all of these somatic complaints, when often the somatic complaints are actually a manifestation of an undiagnosed psychiatric disorder like anxiety and depression. So there's a couple ways. I think first and foremost is realizing that many of these patients don't realize that they have anxiety or depression. So just because they're not coming and complaining, I feel anxious or I feel depressed, doesn't mean that that's not what's going on. So really identifying that that's actually the minority of the way that most of these patients will present. They will present with somatic symptoms more often than a primary complaint of depression or anxiety. So then once you have a patient who comes in with somatic complaints, early on in the thought process, depression or anxiety should be coming up on the radar. And then there's very effective screening tools that are available. There's the GAD-2 or GAD-7, PHQ-2 or 9, which are often used in primary care. Those are really nice tools to pick up depression or anxiety, I think, or asking the question with the patient. I have 5 screening questions that I ask that screen for the major anxiety disorders for patients. Do you have panic attacks? I know it seems like I'm cheating because I'm asking, do they have this? But most patients actually know what a panic attack is because they're so common. Mm-hmm. If they look at me like, I don't know what that is, I'll say, wave of nervousness comes out of the blue and you notice a bunch of things in your body. Stomach bothers you, heart's going fast, it feels like you can't get your breath, you feel dizzy or buzzy and like something terrible is going to happen. If patients have had a panic attack, they know exactly what I'm talking about. Then I'll ask, do you consider yourself to be a worrywart? Patients who have generalized anxiety worry a lot. They will know that they worry a lot and they'll say, oh my gosh, yes. Usually the follow-up question is, well, how much time do you think you spend worrying? And patients will say, all my waking hours, all of the time, essentially. So that's kind of a screening tool for anxiety, for generalized anxiety. Then I'll ask patients, if you're in a social setting, do you worry that people are going to scrutinize you and that you're going to do something that's embarrassing and so people will judge you? So in a social setting can be eating in a public place, walking in a shopping mall, getting on a bus. It doesn't have to be talking in front of a large group of folks. It's a screening question for social anxiety. For PTSD, I ask, do you have any experience that haunts you in some way, any trauma that's happened to you that haunts you? Do you have bad dreams or flashbacks? People who have had those will be able to identify with that question. And then finally, for OCD, do you have these intense thoughts that come over and over in your head that you don't want, or things that you have to do over and over again to reduce anxiety or distress, like counting, checking, washing, doing things in a certain order a certain number of times? That's for screening OCD. I just screened for all the anxiety disorders with those questions. It took me less than a minute. So I think you having these questions is kind of in your mind that you can ask a patient. If you get negative for those things, the likelihood that they have anxiety is very low. So it's a good way of screening if you don't want to use screening tools. And then for depression, when patients come in, you can use the screening tools, the PHQ-2 or the 9, for example. Or you can just ask them, have you noticed your energy is low? You're feeling more irritable or edgy. You're just not getting joy out of the things that you normally enjoy. Going through the other criteria for depression, again, it takes 20 seconds to do that. I I think another important thing is early on in the conversation when someone comes in with a lot of somatic complaints, telling the patient, gosh, you're having a lot of these experiences. When people have these experiences, it can really wear on them, and they can notice it. They're starting to feel down or depressed, or they're starting to feel anxious. So it's a way of backing into, gee, I think the things in your body that you're experiencing actually relate to something going on in your mind, without saying, and it's all in your mind, because that can feel dismissive to patients, because lots of times patients don't realize that depressive or anxiety experiences or symptoms, they feel in their body. Most people don't actually realize that that's the case. So they really think that there's a medical issue going on rather than a psychiatric issue. So I think aligning with their distress about what they're experiencing and then introducing early depression or anxiety can cause these experiences, rather than waiting to the 5th visit and then saying, oh, I can't find any other excuse for why you have these experiences. I think it's depression or anxiety. I think then the patients can feel a little bit negative about the diagnosis, rather than, geez, you have this suffering. Wow, I have a sense of what's going on for the suffering, and we have great treatment for it.